If you're enjoying the Next Breast Thing podcast, be sure to leave a rating and review where you listen to the show. Calling the breast community, the American Society of Breast Surgeons is gearing up for its 26th annual meeting, happening April 30th through May 4th, 2025.
In the dazzling city of Las Vegas, Nevada.
This is the premier event for the breast surgery community, bringing together more than 1,700 surgeons, thought leaders, and innovators from around the globe.
Don't miss your chance to connect, learn, and explore groundbreaking advancements in the treatment of breast disease.
Mark your calendars now. The American Society of Breast Surgeons 26th Annual Meeting, April 30th to May 4th, 2025.
And let's make it a year to remember. Visit www.breastsurgeons.org to register or to learn more. We hope to see you there. Hey listeners, want us to let you know when new episodes are available? Simply hit the subscribe or follow button on the Next Breast Thing podcast wherever you listen to podcasts. Also, join the conversation on our Facebook group by searching the Next Breast Thing podcast group on Facebook.
On this episode of The Next Breast Thing,
A few weeks ago, I had an abnormal screening mammogram.
we do that all the time because we're like, oh, wait, but I have the O or I have this. Oh, I can't get, whether that's a good reminder to us that we need to take care of ourselves.
New things we're trying in my household is daily cold plunges. So let's chat about breast surgery trends. Who would like to start?
Neoadjuvant therapy as a surgeon's tool.
One of the things that's really fascinating in this space are the clinical trials in this space and the escalation trials. And so,
As a new surgeon, I personally am very cautious of de-escalating this early in my career. And my answer to that has been,
Hey, have you all had more patients coming in talking about breast density and requesting MRI?
I'm just curious what this group has to say about cryotherapy. And
what are your thoughts on robotic nipple-sparing mastectomies?
Well, she went there, didn't she?
This is Carla.
Ellie,
Michael.
Susie.
Sitcha,
And Susan, welcome to the Next Breast Thing, a podcast by the American Society of Breast Surgeons for the entire breast community,
We're a group of devoted surgeons from different parts of the country.
inviting you to journey with us into the science of breast.
through the heart and soul of our breast community.
From advances in procedures and patient care,
To personal transformation, we're here to support you.
So, if you're part of the breast community and can't seem to find the answers, this is the Next Breast Thing.
In today's episode, we'll be talking about the latest breast surgery trends. But before we get started, let's begin with some personal and professional updates. Michael, what's new with you?
well, let's see. I talked about my grandbaby recently, and he's gotten a little bit older now since our last podcast. And otherwise, not much has changed. Life is now about grandbaby at my house. So next time we meet, I will be giving you new grandbaby updates. Susie, I know you don't have grandbabies. You have grandnieces and nephews. What's new with you?
I do, and they do grow. This month is going to be extra special to me. I will have run 1,000 days consecutively. My family thinks I'm a bit over the top because I'll even run before I will ski, but it's super exciting. And one of my patients said, "You're a streaker."
I'm working on the 1,000 consecutive days of not running.
There we go.
Opposite. Now we're talking.
Susan, so proud, so proud. Okay, so just tell us about you.
Yeah, thank you. So my personal story kind of spills into professional a little bit. A few weeks ago, I had an abnormal screening mammogram, which totally sucked because I was, just like many of our patients, super delayed in getting my mammogram. I blamed it on the recent pregnancy and breastfeeding, but the truth is I delayed it much more than that because that's what people do. But then I had my diagnostic for the callback just recently and everything was fine. So I was really happy about that. I do sometimes overlook how amazing our radiologists are and the imaging techs, and they actually made my experience very straightforward, very easy, and I do thank them truly. What about you, Susan?
That's great news about your mammogram. And I agree that it is really good at times for us to be the patient. I think it makes us better doctors. And we forget because we go to get our mammogram and we do get a little different treatment. We walk out with those results. We go into the reading room, and at least for me, I look at it along with the radiologist, and then they double read it and triple read it because they're all nervous because it's me and they don't want to miss anything. But to put ourselves in that patient's position, it's way more fun on the side when you have that white coat on. So I'm relieved that everything is good with you.
I've never had an abnormal mammogram, Susan, so I really can't relate.
I'm really happy for you, Michael.
Michael, I may just send in a script for a mammogram because I
mean, how bad could it really be? I don't know.
I think it's important that you are
you're getting a mammogram.
relate.
I had the radiologist tell me she was going to call it abnormal before she actually called it abnormal. It was a screener, so she didn't read it right away. And then she said, don't worry, though. I really think it's just overlapping glandular tissue. And I was still scared. So, yeah, it's tough. It's so hard for our patients with the waiting and not knowing. And I agree, Susan. I think it's a good experience being in those shoes, but I'd rather not.
How long did you wait between your screening abnormal results and your diagnostic imaging?
I am embarrassed to say that it took almost 2 weeks to schedule the diagnostic.
They didn't just read it on the spot.
I know. They definitely tried, but I had operations and clinic. So, yeah, it took longer than I would have wanted.
This is something that I work on at my institution constantly. And we've greatly decreased the wait time between screening and diagnostic or diagnostic and biopsy. I just think it's inhumane that we do this to our patients, and mostly women, obviously, that they have to wait between an abnormal result and figuring out, because they all go, as we all do, I have cancer. And then once someone goes to I have cancer, the next thought is I'm going to die. So if we can shorten that time and get them the good benign result, which frequently it is, it makes an enormous difference. And we've changed their life in a positive way. And it changes what they'll do in the future because they have had a better experience if they don't have to wait as long.
But I think it's also so funny, Sitcha, that it sounds like you were saying you had opportunities to go in, but you were still putting patients first. And I'm like, we do that all the time because we're like, oh, wait, but I have the OR, I have this. Oh, I can't get, whether it be a dental cleaning or it doesn't matter what it is, but you just kind of postpone some of our own health care. That's a good reminder to us that we need to take care of ourselves.
It is, but I would go out on a limb, and maybe I'm entirely wrong, that fear plays a little part in the delaying of getting that. I don't know that I want those results just yet. The holidays are coming up. This is happening. Oh no, I have this event to go to. I'll do it when I get back. I think we're all a little guilty of that because we're human, and fear plays a role in all of these things.
In everyone's hospital, does the radiologist tell the patient the bad results before they get to you, or how's that work?
I don't typically order the screening. So the screening often comes from primary care.
Primary care tells them?
No, the radiologist will tell them. And then we have a really great system in that as soon as that happens, if there's someone who's highly anxious, even if that's not back, they'll connect with us just so they know an appointment is already there. And if it turns out great, they don't need it. Or if they need to walk through, why would I need a biopsy? All those secondary questions, we want to get them in and just be like, take that off your plate. And we're happy to spend that time with them. What about everybody else?
We're in a little bit different system to where if we're doing a cancer follow-up, they'll do their mammogram and then come down the hall and see us. And we're always that touch point. So we'll share the results with them and talk about anything else that needs to happen. There is a whole screening sector that is pretty standard, and that's the radiologist or the ordering physician that order. But in our setup, we're talking to them about their results. And they like that we have been the first person that's been with them throughout this whole journey. And they like hearing that from us.
Carla, how do you do it at your institution?
Our radiologists or radiology nurse navigator is the person that touches base. I'm sure a lot of you have the same system. And then the nice thing about that system is the nurse navigator hands it over to my nurse navigator, because as we all know, and it has to do with the timing as well. Well, I guess I'll give my update. Since our last episode, I have not completed any things on my 2025 list. So there's that. And I survived a January in the Midwest. So I think that's a good thing. Ellie, what about you?
Since the last episode, I also haven't gotten going on many of my goals, but one of the new things we're trying in my household is daily cold plunges. So that's one of my 2025 resolutions.
Did you buy it or make it?
We bought it. Yeah.
Did you have to be hypnotized before you did it?
Maybe. It's really hard to get in there.
Those are great for runners, Susan.
Are you working up to
Yeah.
minutes, or are you just doing a plunge and then out?
I'm working up to minutes, like 3 minutes to start and then eventually like 10 minutes.
I think starting in the second range is good.
Totally. Well, I start with not that cold of a temperature first, and then you get colder and longer.
Or maybe put your big toe in and start there.
You can't do
that. I think that might help.
It is really good for your whole body, and it sharpens your brain. It's like a natural caffeine, and it lasts the whole day.
You just need to move away from California and come back to the Midwest. And then walking outside is just like a cold plunge. So
That's exactly what all my friends in the
see, that's what happens. You've gone to California and now you're doing the cold plunge. Just come back here.
I'm desiring cold. Not really, but yeah. Why don't we move on to our topic? Today's topic is let's chat about breast surgery trends. Who would like to start?
Okay, let me start. So I was asked to give a grand rounds where I trained because now I'm a big deal. They wouldn't talk to me for 20 years, but now all of a sudden I'm something else. And they wanted to talk about standard of care. And I thought that was totally boring. And I thought, what are the trends? Because this is what we're going to talk about. And it's neoadjuvant therapy as a surgeon's tool. And I think that's something that we are seeing more and more of as we continue to treat patients. You've got triple negative patients. And if you're not thinking neoadjuvant therapy in triple negative patients, then you're doing it wrong. And if you're not thinking genetic testing, you are depriving patients potentially of a treatment afterwards. HER2 patients. And I think we're going to quickly see that move into luminal breast patients as well. It's a real shift for us. When I was trained, the whole idea of neoadjuvant therapy was to shrink a cancer that you couldn't do a lumpectomy on, and then you could do a lumpectomy. But now it really is response to therapy, and it changes what you do as a surgeon. It gives you an opportunity to do things completely differently. And if you're not thinking about neoadjuvant therapy when you see your new breast patient, you really are maybe depriving them of even overall survival in some instances. So I think that's something, I'm going to talk about that in the grand rounds. And I think it's something that we need to really change our mindset on how we deal with therapies. It's not just the surgery, followed by the chemotherapy, followed by the radiation therapy. I think it needs to be integrated, and maybe some of the order needs to, in certain circumstances, definitely change.
One of the things that's really fascinating in this space are the clinical trials in this space and the escalation trials. And so it really gives us an opportunity to assess a specific tumor's response to chemotherapy or immunotherapy. And that's been the big change that we've seen over the last couple of years. And we have a couple of the de-escalation trials open, and it's fascinating. It's fascinating to see some of these patients who get less treatment than they maybe normally would have and are still getting pathologic complete responses.
Michael, if you're discussing standards, and I'm always good for the big picture questions, as you know, who defines standards?
There's a legal definition of standard of care, which is sort of community-based. I think we've moved beyond that now. It's certainly more national based now. And that's why I chose to pivot and present another topic. But that's a great question, because what may be standard in one community, you could argue, is not the standard nationally. That is a legal term.
It is. And I think we have to be very careful. Standard of care is a legal term that is used against us every single day. And by giving a talk with that title, you're just feeding into it. So I think it's an important topic, but standard of care, what people hear is there's one way to do it. And we know there's rarely one way to do it. That's why we discuss options. I think neoadjuvant treatment, not neoadjuvant chemotherapy or neoadjuvant endocrine, I think there's a range of options. I think neoadjuvant treatment is enormously important. In fact, probably half my patients are on neoadjuvant of some sort.
Wow.
So I think it's incredibly important. I'm just raising the issue of the term standard of care or standard treatment.
I think that's a good point. But again, that's why I pivoted.
Yeah, I think that's a really great point. And it's funny, I'm giving a talk for our primary care doctors, and we're making it multidisciplinary. And our closing thought is, this is complicated. And we need to have that multidisciplinary approach because there are a lot of trials out there and there are a lot of these changes in therapies. And how are we pulling that together to not only look at the patients across the United States, but now how we're able to dial it down to the patient with their tumor and what is a good pathway for them. It may not be the only pathway, but where are we walking with them and putting that forward? It's an interesting topic.
My question as a new surgeon, all these de-escalation trials are out, like Sound trial, Comet, all these things are being presented about de-escalation. I personally am very cautious of de-escalating this early in my career. And my answer to that has been presented at a multidisciplinary tumor board and kind of navigate that. Realistically, how long does it take you to integrate that into your practice?
I think you have to have a champion in each of the areas. If you're swimming upstream and nobody else wants to de-escalate, it's harder. Mm-hmm. But if there's a core group that sort of embraces de-escalation and your medical oncologists are on board and your radiation oncologists are on board, then I think it's a lot easier. So you've got to kind of find the champions within your system that embrace the idea. And then I think you can move it forward a whole lot easier. But if it's just you and nobody else wants to play along, you're not going to get anywhere. So I think that's a way of speeding it up.
I agree. And like Z11 would be an example. If you didn't have other people on board, like you would be out on an island. With that or WISE criteria for sentinel lymph node biopsy too, you really do have to have a multidisciplinary buy-in. And is that appropriate? And really looking at that. Sidra, what were you saying?
Yeah, no, I was just going to say our national guidelines, they don't keep up as fast as the science changes. But I think that NCCN does a great job of updating things when it's appropriate. And in terms of Ellie's question about uptake, I think it's highly variable. Z11 took forever to get adopted into the scientific community, whereas with the results of 1071 and the omission of axillary dissection after neoadjuvant chemotherapy, when you had an excellent clinical response, that came through much, much faster. And I think part of it is the scientific community was ready for something like that, whereas Z11 kind of took everybody by surprise. You certainly can look to national guidelines to help you in your decision making. For your talk, Michael, you can pivot away from standard of care and say guideline concordant care. I actually just did a review with our surgical oncology fellow of the NCCN guidelines for adjuvant therapies, and there's multiple sections on neoadjuvant care, the benefits, the principles of neoadjuvant care, the benefits of it, the use of additional therapies after neoadjuvant chemotherapy, after surgery, after being able to assess the response to the neoadjuvant therapy, such as capecitabine and TDM1. This is all in our guidelines already. And I agree. I think that the consideration for neoadjuvant chemotherapy for just about every case needs to be there. But in many cases, it's still appropriate to do primary surgery.
Hey, have you all had more patients coming in talking about breast density and requesting MRIs recently? I feel like this year I've had a lot more people and talking about famous people who have had diagnoses that way. Anybody else experiencing that?
No.
I work in New York and Connecticut, and the whole breast density issue began in Connecticut. So it is pretty standard in New York and Connecticut with dense breast tissue to get an ultrasound. So just at screening. So we're not waiting for it. So the patients aren't usually asking for the MR because they're getting the screening ultrasound. So it's a very different mindset. And that goes back to what Michael said is standards regionally may be different than standards nationally or even locally. So I think it varies depending on where we each practice.
All right, I've got a change of pace for you guys. Talking about breast cancer surgery trends, what are your thoughts on robotic nipple-sparing mastectomies?
Well, she went there, didn't she?
I was going to say it depends. How much time did it take?
Well, that's all the time we have today.
I don't know a ton about it, to be honest with you, but I will say as a robotic surgeon, I'm usually like, ugh, why would you do this robotically when you could just do it open? But on some of those nipple-sparing mastectomies, having that reach and having the light, I think there would be a lot less stretching and the plane would be so much clearer because it's so magnified, but I don't know a ton about it.
I don't think most of us do. The question's up in the air, and as you probably know, some people feel very strongly about it. Some people probably very strongly against it. But I think it's worth just bringing up in the sense that it's such a different way to look at how we do breast surgery. And Michael, you talked about some of the fun toys that we have. I don't think we would have ever imagined having a robot in the room for breast surgery cases, but I think it's interesting that people are exploring it. It's being done appropriately on a clinical trial basis. And again, there's people that are kind of pro it and people that are con it, but
I think it's also great for teaching.
Mm-hmm.
Oh, because as you know,
an exclusionary shift. I think we started, there have been different points even in breast surgery where there are exclusionary shifts where someone doesn't know how to do ultrasound, for instance, and that excluded them, or somebody didn't really know how to do sentinel node and excluded them. I've never done anything robotically ever. Unlike Susie, it's never been a part of my practice. I wonder if that would force me out or force me to have to learn something that I'm completely unaware of.
I think if it's shown to be an appropriate surgery, I think it will take a long time for it to be the standard of care for how we perform nipple-sparing mastectomies. I always say as a surgeon, I like to have a lot of tools in my toolkit, and I think it will be an additional tool, and maybe some patients will be great candidates for it and seek it out. But I think the teaching part, Susan, I think is interesting. I just learned a lot about some of the systems and the amount of information that the robot can give you about how much you're using your right hand and how much you're using your left hand and what you're doing with that. I think that part's fascinating. I mean, I'd love to just put something on my own hands while I'm operating and be able to tell how efficient I am as a surgeon.
Michael, I think you're going to have probably great grandkids by time this would be everywhere.
Yeah, the grandkids will be learning.
You train them to do that.
the breast surgeons would actually have to get robot time, which would be a whole different story.
Gaining the proficiency for something like that and being able to complete it in a timely fashion, I think is going to be the biggest impediment to adopting something like that. But speaking of tools in your toolkit, one of the things I had on my list for trends in breast surgery was the use of cryotherapy. And I'm just curious what this group has to say about cryotherapy.
Well, Susan was the PI of ICE3, so probably nobody other than she is qualified to speak, at least on that trial and what we think about it.
I think, as Carla said, it will be a tool for us in the toolbox. Do I think that we will see the day where every woman with breast cancer gets cryoablation? Certainly not in my lifetime, nor do I think that would be an appropriate use of cryoablation. As of this recording, the FDA has not issued their final guidance on it. The preliminary panel did vote in favor of IceCure's cryo. So that is machine specific and technology specific, not cryotherapy of the breast in general. So that was another subtle point, but I think an important point. So I do think they'll require other trials to be done or registries to be done. I think that it's TBD to see where this goes. But Michael, I know that you certainly enrolled numerous patients on the ICE3 trial. So what are your thoughts? And I'll just give the caveat that Michael and I have slightly different thoughts on where cryo is heading and the ideal patient for cryo.
I think we're going to crawl before we walk on this, but we see the transition in so many other therapies. You wonder if dead is dead. If you can kill a tumor within the breast, Does it matter what its tumor type is if they get appropriate adjuvant therapy? I don't know that. I will tell you it is an easy...
That's a really far reach, but keep going.
Okay, yeah, here. Hold on.
I mean, you're already there.
I'm going to dig a little deeper here.
I gave you
Here.
enough rope to hang yourself.
Give me my shovel.
You are going right on.
No, but I think right now in the group that was identified in ICE3, which is 1.5 centimeter, they tried to get luminal A breast cancers that were clinically node negative, no excessive DCIS. It is a small subset, but we saw great uptake with the patients. When you offer that to the patients and you're not doing sentinel lymph node biopsy generally on these patients anyway, you're not radiating a lot of these patients anyway, and you gave them an opportunity to never step foot in the operating room and in 30 minutes have their local therapy taken care of and again, not have to go to the operating room, they appreciated that opportunity. I think it's something that everybody's going to have to come to grips with because I think it is something that's going to be in your toolbox and you need to be able to do ultrasound to do it. The biggest concern you need to be aware of is if you're not doing it, somebody else is. And the radiologists are training their radiologist how to do this. You can discuss whether that's appropriate or not. We spend a lot of time worrying about the right patient, the effects of it, what their follow-up is going to be like. And maybe not so much when it's a work order. Someone requested to cryoablate something in the breast, and maybe a medical oncologist follows it. I know I'm getting out there. I'm watching Susan give me the...
Watching my head explode. So
yes,
Michael and I, throughout this trial, I've had multiple discussions on this. I think that we both agree that this is a treatment option that is here to stay and will increase. That's about the beginning and end, maybe, of what we agree upon. I think that the uptake will vary greatly geographically because, as Michael said, his patients were so grateful and they signed up for the trial without a second thought. That is not the case in New York.
Interesting.
That was not the case at all. And one of the biggest issues is women come in with a small breast cancer. Maybe they feel it, maybe they don't, and 100% leave the treatment feeling that ice ball. So that uptake, that acceptance may be different in Memphis than in New York. And I do think that we will see some regional differences with this. I think overall, it's a great treatment option.
Well, it creates fat necrosis in the breast that doesn't go away. So depending on their breast size and depending on how superficial it is, depends really about how much they're going to feel it. But it doesn't go away, and it's always on their mammogram. Now, it's a classic look of fat necrosis, but she's exactly right. It is something that could be felt, and you'll feel it forever. It's fat necrosis.
Well, and I guess imagining patients feeling it and being like, do I have a lump? Did it go away? Did it not? And you reassure them. And then does this end up being a saga in an office visit?
Setting expectations with the patient that they need to know this. And it's also setting expectations with your radiologist because on ultrasound, this thing looks pretty horrible.
But it's also acceptance of that expectation. We can educate and set expectations. And there's going to be a certain patient population that will say, I did not feel the cancer before. If you are telling me I am going to feel this, I am telling you it will give me fear and emotional distress every day. That patient should just go to the operating room.
Totally agree.
There's a lot of things that you look at when you look at clinical trials and you look at outcomes. We look at survival, we look at local recurrence, we look at cosmetic outcomes. We have lots of patient advocates who are very involved in clinical trials now for reasons just like what you guys were talking about, because we as oncologists are like, your cancer's gone. It's not going to come back. You didn't have surgery. This is a great outcome. You had a great outcome. And patients will go, no, I don't like how this feels. And so it's interesting to kind of hear all of these points from you guys regarding the trial.
Having a partner feel that, was that tracked at all?
Was not part of the trial.
Satisfaction was, though, and it was high.
Patient satisfaction and what Susie have just brought up, sexuality and body image, are very different things. We also have to look at the age of the patients. So again, I think this is a great option. I don't think the uptake will be as high as you do, Michael, because I think it's geographical. I think it's acceptance. I think it's quality of life. I think it's body image. I think so much more will go into this rather than the cancer's out. Because if that's what it is, we can say, then everyone would get a mastectomy. Cancer's out, I'm okay. No, there's so much more that goes into breast cancer and treatment options and quality of life and body image and how we feel about ourselves and our emotional stability and how we are emotionally after this in fear. So I think we have to take a look at all this. And Susie, I think that there will be, as part of registries, those are the things that we should be looking at, in addition, obviously, to outcomes with cancer and local recurrence and outcomes. But I really do think that we should be looking at quality of life, which is very different than satisfaction. Because the questions were satisfaction with the procedure. Oh, yeah, this procedure was easy. It's all how you word it. We know that. And I was one of the people writing the protocol. So I think it was a long time ago that we wrote the protocol, because we do have 5-year follow-up, which is great to have on this technology. So I think there's more to come. I think it's incredibly promising. I am thrilled that the initial recommendation was to approve this. We'll see what the full FDA has to say about it, but I'm very optimistic and I hope that it's approved in the right patients.
I like the fact that they asked patients what they thought about how it looked, and they also asked surgeons. It's always interesting when you're reading articles or you're looking at different things in terms of, I think it looks great, and how patients sort of look at that as well. So I'm glad that both of those pieces of information were pulled.
Just like asking about blood loss, what a surgeon thinks and what an anesthesiologist thinks and the nurse. I mean, like it is about perspective. And I think that also hit a little bit on this, Susan, what you were saying. It was reminding me of what's important to that individual patient. I mean, there's some people who are like, I breastfed, I'm done. I don't need these breasts. And then there's other people who are very, very specific about what they want, whether it be cosmesis or related to something else, and making that an easy conversation and just asking what through this journey is important to you and trying to serve that need and that want from them while providing them with a path that's going to be cancer-free.
Well, believe it or not, we are just about out of time. But before we go, let's quickly summarize what we've learned. Michael talked about neoadjuvant therapy and how it's a surgeon's tool. Susan discussed the point of what really is the standard of care. How do we define that, and how does that differ versus where you live? A robotic mastectomy was also discussed. That's a hot topic that we will see how it unfolds. Also, cryotherapy. This is another emerging topic, and we brought up a good point about the important things to the patient versus what we're measuring in protocols and clinical trials. So to our listeners throughout this breast community, we're so excited you've joined us on this journey, and we will see you all next time on the Next Breast Thing podcast.
We look forward to connecting with you on the next episode of The Next Breast Thing, a podcast by the American Society of Breast Surgeons for the breast community.
Join the conversation on our Facebook group by searching the Next Breast Thing podcast group on Facebook.
Finally, the content within the Next Breast Thing podcast represents the views, thoughts, and opinions of the co-host and may not necessarily reflect the views, thoughts, and opinions of the American Society of Breast Surgeons.
Until next time, this is Carla,
Ellie,
Michael,
Susie,
Sitcha,
and Susan. And always remember, if you're part of the breast community and can't seem to find the answers, this is the next breast thing.